All right, let's talk about childhood sleep problems. Let's be honest, they're one of the most common and sometimes trickiest issues that show up in our clinic rooms. So, in this explainer, we're going to give you a really clear, practical framework to navigate these consults, so you know exactly when to reassure and when you really need to start digging a little deeper.
We've all been there, right? You hear this, or some version of it. It's that classic opening line that could take the consultation in a couple of very different directions. Our job is to figure out the story behind that snoring, because that's where the real diagnosis is hiding.
And you're going to see this a lot. Up to 15% of all children snore. Now, for the vast majority of them, this is totally fine. It's just a normal variant. It's noise, basically, with no underlying problem. So our first instinct, and, often the right one, is just reassurance.
But, and this is the absolute key, in a small but really significant group, that snoring is a signal for something much more serious, obstructive sleep apnea. And here's the game changer. Unlike in adults, pediatric OSA is often completely curable. That makes spotting it one of the most important things we can do.
Okay, so how do we actually tell the difference? Well, it all starts with our clinical assessment, gathering the right clues from the history and, of course, the exam. This is it. This is the central question that drives our entire assessment. Every single thing we ask and every sign we look for is all about getting a clear answer here. Is this just noise, or is there a genuine obstruction going on? To get to that answer, we need to probe for these specific nighttime symptoms. We're listening for the evidence of obstruction. Are there pauses in breathing, gasping? What about things like arching their neck back to try and open up that airway? There isn't a formal scoring system or anything, but your clinical gestalt is pretty simple. The more yeses you get to these questions, the higher your suspicion for OSA should be. Now, this right here is a massive clinical pearl. Forget the sleepy, tired adult model of OSA. In kids, that fragmented sleep from all the microarousals messes with their frontal lobe function. So what does that look like? It often shows up as daytime hyperactivity, poor concentration, and behavioral problems. It can look exactly like ADHD, and it should always be on your differential. The physical exam can then add the final pieces to the puzzle. A really focused ENT exam is key here. You're looking for any signs of obstruction, things like massive tonsils, nasal speech, or stertor, that's that coarse, snorting sound of nasal obstruction. And, of course, always plot their BMI, since obesity is a big risk factor. These are the signs that help you build your case. Okay, we've gathered our clues. Now we move on to the diagnosis and, crucially, the red flags. It's all about sorting the signals to figure out what to do next. This table breaks down the two most common things you'll be thinking about. Just look at the primary issue. Behavioral insomnia is all about trouble getting to sleep, while OSA is about the airway being blocked during sleep. This leads to really different daytime effects. You get irritability from just not enough sleep versus that classic hyperactivity from fragmented sleep. And often the exam findings are the final giveaway. Now for the stuff we absolutely cannot miss. These are the red flags that demand an urgent investigation. Nighttime pain or sweats? That could be a malignancy. Stereotyped repetitive movements could be seizures. Look, they're rare, but these possibilities are exactly why we always have to keep that broader differential diagnosis in mind. So, assuming we haven't found any red flags, what can we actually do in primary care? Let's open up the GP's toolkit. For behavioral issues, the foundation is always good sleep hygiene. It's all about building a solid plan with the family. So you're reinforcing all the good stuff, like a regular routine in a dark, quiet room, while actively shutting down the negatives, like screen time right before bed. Honestly, this alone can solve up to 30% of primary insomnia cases. And for those kids who have sleep onset association issues, the ones who need a parent right there to fall asleep, this is a fantastic, concrete technique you can share. It's called camping out, and it's basically a process of gradual withdrawal. It really empowers parents with a clear, step-by-step plan to gently reclaim their evenings. But what happens when our primary care toolkit just isn't enough, or when our suspicion for OSA is really high? Well, that brings us to our final section, referral and specialist care. The referral pathway is actually pretty straightforward. If you've got simple snoring with zero features of OSA, the right thing to do is reassure the parents. No referral needed. But if there's snoring plus any of those concerning night or daytime symptoms, that's an indication for an ENT referral. It's really that clear-cut. And it's really helpful for us to know what happens next so we can manage expectations. For most children with simple OSA that's caused by big tonsils and adenoids, an adenotonsillectomy is curative. It can be a truly life-changing procedure for these kids.
So, surgery is often the answer for OSA. But what about medication for the behavioral issues? Well, this inevitably leads to questions about melatonin. So just as a quick refresher, melatonin is our body's own sleep-regulating hormone. It's what controls our circadian rhythm.
Now, when it comes to prescribing this, the rules are really strict. First and foremost, it has to be initiated by a specialist. It's unlicensed for this use in kids, and honestly, it only offers a modest benefit. It improves sleep onset by about 30 minutes on average. If you are managing a shared care agreement, remember to start with 2 to 3 milligrams of an immediate release form, and just as importantly, make sure regular drug holidays are planned to see if it's still needed. So let's end where we started, with Jimmy. After his adenotonsillectomy, his mother said he was a different child. It's such a powerful reminder, and it leaves us with a critical question to take into our next clinic. Could that next child who presents with so-called bad behavior just be a child who is completely and utterly exhausted? It's a diagnosis we just can't afford to miss.